Assistant Professor from SWIMS Tirupati, currently working as consultant nephrologist at Amara Hospital, Tirupati. The topic for the discussion is about alarms and drug dosing in CRRT. It's kind of a sometimes a overlooked aspect of CRRT, often because of the technical difficulties involved in using the CRRT machine. And also the drug dosing is one important aspect of CRRT which often we have a kind of blind spot on it. I think post this talk we'll be gaining some more information from Dr. Siva Parvathi. Over to you.
Thank you. At the outset, I would like to thank Hyderabad Nephrology Forum and my seniors because I am back home. This is my home institute. And the topics given are so huge, so I tried to modify that, what to do and what not to do. Because since morning we have seen the basics and we have seen the doses and anticoagulation, so that everything is set now. Can we sleep? Because in regular HT we just give the prescription and we sleep, or we just hand it over to the technician. But it is not so in CRRT because since morning everybody is telling we have to receive multiple calls, we have to see. So what is so big difference in monitoring of CRRT that we are going to see now? I come from this place. I practice at Tirupati where we see a lot of people coming to the place, but nobody stays there for treatment. So as being discussed in the morning, so we have to convince the patient to stay there and get the treatment. Like until we have that clearance, we have a less opportunity. But in the last 10 months, I have the blessings of God. I have and the confidence of patients that we have done 9 patients in the last 10 months, and I'm going to discuss all the complications and how we have done with these patients. And I worked in this hospital, Amara Hospital from Tirupati. So I've divided my talks into 3 basic categories. One is the alarms and troubleshooting. The second one is monitoring and complications, and the last one would be drug dosing in CRRT. So we all know this. Alarms used in the biomedical equipment are of 3 categories: green, orange and red. What I would like to understand is, in a CRRT machine or when a patient is on CRRT, we don't want any downtime on CRRT, because since morning all the speakers have been trying to tell you that the delivered dose is different from the decided dose, or the delivered dose is different from the prescribed dose, and there are various reasons for this. And one of the important reason is there should not be many alarms, there should not be many breakdowns in between the circuit. So when you see a red alarm in CRRT, that is very, very important, because the machine will be practically non-functional if you see a red alarm. So in intermittent hemodialysis, that doesn't make a big difference for us, but in CRRT it is going to make a big difference because it is going to affect the dose delivered. So I would like to impress upon you this picture. Morning Shakthirajan sir has told you this. So why do we need so many monitors? Because what exactly happens in the machine? If you see this circuit, the first is, I don't know if I can have a pointer, but I'm comfortable. The first is the axis. So from the axis, we take the blood from the patient. Yeah. So from here, the blood is drawn from the patient, and here we have the facility for the anticoagulation. From there, the blood passes through the blood pump. So here we have a pressure that is called as axis pressure. So the pressure with which the blood is drawn to the circuit. After the blood pump, the blood is pushed into the filter. So here also we have a pressure. So this is called the filter pressure, and here we have the transmembrane pressure which acts within the dialyzer, and from here the blood is again pushed back to the patient. So I am using the words pull and push. This is very, very important to understand. Here the blood is pulled or sucked. So the axis pressure is usually a negative pressure, but the pressure that comes after the blood pump is going to be positive, and the TMP as well as the return pressure or the outflow pressure, these are all going to be positive pressure. So when we have 2 different pressures, obviously there will be a pressure difference. So we have a monitor to note this pressure difference. And this is also important because in CRRT we have an effluent pump. Here also we are trying to generate positive pressure to get the ultrafiltration, except in CVVH mode where it will be a negative pressure to draw the ultrafiltration. So here also we have a pressure. So from this, the various alarms are axis pressure alarms, filter pressure alarms, disconnection alarm, air in the circuit alarm, and blood leak alarm. So the last 3 alarms, you are very much familiar with the intermittent hemodialysis techniques also, but the first 2 alarms that I am going to do in a great detail. So what do we need to understand something about the basics of pressures and flows. Morning, the first talk we had fixed law of diffusion. I don't know how much or how many of you would remember that fixed law of diffusion was the basis for the solute clearance by CRRT apart from hemofiltration. Now I am going to introduce some other law, that is Poiseuille's law. If you see, this is a tube and the fluid is moving from point P1 to P2. So obviously the pressure in the P1 should be higher to draw the fluid from point P1 to P2. So whenever the fluid is moving in a tube, you will see what is called as pressure drop, and this pressure drop is essential for the movement of fluid in any tube, for us for the movement of blood in the circuit. So that depends upon various factors. So this I have a permanently decreasing pressure is formed along the pipe in the direction of the flow. The greater this pressure drop, the faster the fluid moves, and also the greater the flow rate will be. This is what we have been discussing. So our blood flow rate should be very high to achieve the greater doses and high effluent volume. So this is the Poiseuille's law that I would like to understand, all of you. So if you see the flows across a tube, the volume of the flow rate is given by the formula Q is equal to P1 minus P2 by R. So P1 and P2 we have seen the pressure at high end to the pressure at lower end. And what is R is the resistance. So how do you calculate this flow resistance? 8 into N into L by pi R to the power 4. So this R is the radius of the tube, morning we have discussed, and length is the length of the tube. We have a very long circuit length, and I am going to spend some time on this N. Morning also we have discussed this viscosity, because as soon as your technician calls you to tell the prescription, so he will ask what is the hematocrit. We need to enter in the mission about the hematocrit. So why is it the hematocrit important? Where is it playing the role? The hematocrit is playing the role here. So N is the viscosity. If your hematocrit is very high, your viscosity is going to be very high, and ultimately your filter time is going to come down. So these things are certain basic things. Blood is a non-Newtonian fluid. So the Poiseuille's law that I have told you is for Newtonian fluids, and though we do not consider blood as a Newtonian fluid, we try to apply this physiology in understanding the circuit life and circuit patency in the CRRT. The most consider the blood viscosity values between 3.5 to 5.5. As discussed, the hematocrit values and the blood viscosity changes from time to time, and morning the speakers have told that every 6 hours we give the hematocrit only at the start of the prescription in CRRT. But if the CRRT needs to be effective, we need to change the current hematocrit value at least once in 6 to 12 hours, because that is going to change the viscosity and it is going to affect your filter half-life. So this at higher shear rates, a rise in hematocrit of 1 unit would cause an increase in blood viscosity of 4%. That means if the patient is on multiple inotropes, there will be higher shear stress. So at that time your viscosity is going to be high. Though your hematocrit is fixed, your viscosity is going to high, and that is going to change the flow across the tubes. So now we understand that extracorporeal circuit is nothing but a tube, and it offers multiple resistances to blood flow and has several sensors which enable pressure monitoring at various levels of the circuit. That is why, because we have multiple pressure points, multiple sensors, we have these alarms, and it becomes our duty to monitor these alarms, because the final goal is protect the filter, give the effective dose. These two are our final goals. So as I have discussed, A is the access pressure. I just want everybody to take this picture into your brains. The first one is the inflow or the access pressures. So the access pressure is the negative pressure which is required to be generated to move the blood from the patient. Normal values is minus 50 to 200. So just remember, the first one is the access pressure, which is at the catheter of the patient, between the catheter and the blood flow. The normal values of minus 50 to 200. It is an indicator of the functioning vascular access. So any acute drops in the inflow pressure may also be encountered during patient's mobilization and coughing. Suppose you get a call in the middle of the night that we have access pressure alarm. Immediately don't jump and say that, there may be problem in the catheter, change the catheter like that. So ask the nurse if the patient has been changed the position for any investigations, or if the catheter is okay, is had kinking of the catheter is there. So these are the minimal things that you need to keep in mind before you go for a big changes. The next is the outflow pressure, which is the last one. This is the return pressure. It is the positive pressure generated to return the blood to the patient, and usually it is between plus 50 to plus 200. And filter pressure, it is between the blood pump and the filter. So this diagram C represents the filter pressure. So it is the highest pressure point because we are pushing the blood through the circuit. We want highest diffusion, highest convection. So it indicates the functional state of the hemo filter and hollow fiber spermie. So this is very important. You forget all the pressures, but two pressures that you want to remember out of my talk. One is the filter pressure, the other is the TMP. Suppose if your filter pressure is going on very high, that means the filter is having trouble taking the fluid. How can the trouble come? Morning we have seen that can come from fouling. So it is gradual deposition of the proteins, red blood cells, all the debris. You get the increase in the filter pressure. So important, remember, filter pressure represents the filter's life. So a rising filter pressure is indicative of filter clotting. It may be also influenced by the transmitted outflow pressure. Suppose you have a problem in the arterial end of the catheter. So you are getting back pressure. At that time also your filter pressure will be high. And this is the effluent pressure. It is measured between the filter and the effluent pump. And it is corresponding to the positive pressure required to target the ultrafiltration. This we have discussed. So during the therapy, as the membrane pores tend to undergo clogging, the effluent pressures also tend to become more and more negative. That means you need to work more to draw the same amount of fluid. So effluent pressure is going high, filter pressure is going high. That means your filter is dying. You have a prepared for changing the filter in order to decrease the downtime on CRRT. This is another term, that is filter pressure drop. So that is E. So the filter pressure drop is between the filter pressure and the outflow pressure. So a slow and continuous rise of the pressure is it is an alert to intervene aiming at minimizing the clotting. So two more points. So if the rise of the filter pressure is very slow, that means suspect clogging or fouling, whatever we call. Suppose if the rise is sudden, dramatic, then you suspect some clot in the catheter, or you suspect some sudden event in the catheter and that filter, so that you have to change the filter immediately. So TMP, as I said, it is the pressure gradient on either side of the filter. So the hydrostatic pressure as well as the oncotic pressure gradients of the filter determine this TMP. So morning we have seen that majority of the membranes of CRRT available now are they are very good hydrophilic. They can they clear a lot of water soluble solutes. It can be estimated by the following formula: filter pressure plus return pressure by 2 minus effluent. Don't try to remember all these formulas. I just kept it. Try to understand the concept. So it is nothing but that TMP represents the filter pressure across the filter. So F is the TMP. So a rise in TMP secondary to membrane pores clogging or some form of clotting along the circuit. So high TMP with normal return pressure, that means the catheter is very good. Return pressure means your arterial side is very good. That means there is some problem with the filter. Suppose you see high TMP but high TMP and high return pressure, that means either the filter or the return line is also having clot. So these are the basic pressures that we see in the CRRT machine, the basic alarms. And how do we go about troubleshooting? So once you understand the basic physiology only, you go for a clear troubleshooting. So low axis pressure alarm, when you get it is less than minus 250. So the problem can be with the vascular catheter. So try to check the catheter issues. Try to pull out the catheter little bit, rotate the catheter, check for the flows, because if the catheter tip is abutting the wall also, you will have very low venous pressures. Next is the problems with the intravascular volume. Suppose if the patient is very hypotensive and you set very high blood flow rates, at that time also you get this low venous pressure alarm and the blood flow rate is very high. So how do you do that? Malposition of the catheter, rotate or pull out slightly. Suppose if you see that there is obstructed vascular catheter, try to aspirate, remove the clot. If it is then suppose and one more thing is, whenever you get any alarm, try to see the clamps. Anywhere we forget to release the clamp. So if there is any clamping done across the circuit, try reducing the blood pump speed down the line. If still low, better you try to swap the axis. So change the axis from venous to arterial line. This will increase the recirculation and it is only a temporary method. Press the blood pump and balance the keys to back recommence the treatment. So as I told, agitated patient, check for signs of decreased circulatory volume. This is by increasing the inotrope support and ensure respiratory pattern, because suppose if there is an increased intrathoracic pressure or increased intra-abdominal pressure, we need to go and check the ventilator setting also. They will also cause this venous pressure alarms. Suppose this is a tricky situation, the nurse, as I told you, the venous pressure alarms are minus 50 to 200. Suppose the nurse says that the pressure is 20. What do you do in the night suddenly? What must have been happened? You must have cannulated the artery. It is not the vein. So we need to change our catheterization. So this is about the low pressure alarm or the venous pressure alarm. Then second, the high return pressure alarms. That means, as already discussed, the highest pressure is 50 to 150. You will get an alarm only if the return pressure is more than 300. If the high return pressure is there, check with the arterial side of the catheter or the filter. Next is the high filter pressure. Again, high filter pressure, as I told you, it can be either gradual rise or it can be a sudden rise. It indicates the dying filter. Filter pressure for filter's life. Blindly you can remember like that. So the normal difference is 100 to 250 if it is alarm gets when it is more than 250 millimoles of mmHg. So the various causes are filter becomes clogged with filth or natural filter degradation during the course of dialysis. Sudden rise may be due to kinking or clamping of the line, clotting, or excessive high fluid replacements. So we have discussed in the morning, if you are giving more, because the patient is very hypotensive, we want to maintain the hemodynamics, we give more and more post pump dilution. At that times also your filter return pressures will be very high. So go and check the fluid replacement. The replacement may be high compared to the filter size or compared to the patient's body habitus. So look for other high pressure alarms. As I told you, whenever you get high filter pressure, always go and see the high return pressure also, because the problem is either in the arterial side of the catheter or it will be in the filter also. If only filter pressure is high, then only the problem is with the filter. Troubleshooting, just ensure kink free going in the filter, there is no clamp anywhere, appropriate pre-dilution replacement fluid, and if the filter has clotted, at the end try to replace the filter, which should be the last resort we should be trying, because we should try to check out all the other reasons, because the filter is very expensive. We cannot tell the patients often there is some problem, we need to change the new filter. So this is the TMP alarm. So the normal is less than 250 and we get TMP alarm only if it is more than 450. This thing you should remember, because we don't get TMP alarm immediately, but the TMP starts to raise early often before we give alarm. Morning we have discussed, we are all creatinine centric. So we wait till creatinine rises, we don't initiate this. Similarly, don't try to be this number centric. Don't wait till the alarm comes. The one thing that you want to monitor on CRRT without going for an alarm is TMT. Because if there are certain things that we can do, we can save the life of the filter. Like the previous speaker, we have to decide on the anticoagulation, or we have to decide on the replacement fluid correction. We look for the patient's volumic status. These are all very important to protect the filter's life. So causes are clogged filter, kinking, embolus, clot, excessive ultrafiltration rate, and replacement fluid rate is too high for the filter size. This we have discussed. So check for the clamp. The one thing that we can do whenever we see clogging of the filter is, through the rescue line we can try to flush the filter and see. Morning we have seen the fouling can be external and internal clogging. So at the time of external clogging only, if we have realized, flushing would help. Suppose if it is internal fouling, then nothing would help and we need to change the filter. Increase the blood flow rate and decrease the dialysate flow rate. So these are all, I tried to summarize about the pressures and pressure alarms. Air detection alarm, it is something like in the regular HD alarm. It indicates air in the circuit or some small air bubbles in the circuit. I want to highlight that we all know there may be many causes for this air in the circuit, but the most important thing is to fill the blood air trap chamber to the mark that is specified on the machine. Most of the times we don't fill that till that mark. So the machine starts to recognize air in that bubble trap chamber and it gives an alarm. So that is very important. So check for any loose connections, proper priming, or the blood level is too low in the, because this very often we see and we try to train the technicians about the blood level in the bubble trap chamber, and make sure that air detector is properly attached. Look for actual air bubbles, try to aspirate them, and most important thing is, if you see froth in your circuit, don't try to do something with the patient on the circuit. Just simply remove the circuit and take back the thing. You don't try to send the air to the patient. That is very important. So circuit is full of froth, blood cannot be returned and you need to set up a new circuit. So this is the blood leak alarm. This is again, the words are really nice, so I try to paste the same. It indicates that the blood detector in the effluent line has found either blood or something it thinks it is blood. So blood leaking alarm is not always blood. So ruptured filter membrane can cause leak of the blood, and you can see the ultrafiltrate also is colored before you get the blood leak alarm. or sometimes you can have severe hemolysis. And recent dose of hydroxycobalamin injections, so methylcobalamin injections or something they get, this causes discoloration of the body fluids. Sometimes patient is on ATT, of late we see most of the patients, they also cause discoloration of the body fluids. So this is very important. And the fourth one is dirty mirror in-housing. I must thank the technicians in NIMS department, because when we open the machine and we see, the technician, if he really well versed with the machine, he cleans the mirror in the blood detection mirror. If you are not properly cleaning that mirror, there is dirt in the mirror also, you get frequent blood leak alarm. So you should identify that, so that any alarm, our goal is not to get the alarm or try to correct it at the first, because we are going to decrease the delivery dose. This is very important. And troubleshooting is stop dialysis immediately and replace the filter, clean the mirror in-housing and replace the chamber. So try to teach the things that can cause false positives also. Consider false positives. So finally we come to the final decision, when you change the circuit on filter. So there are no hard and fast indications actually. So it is all patient individualized. When the pre-filter pressure is consistently above 270 millimeters of mercury, or the TMP is about 250 and the filter is over 72 hours old, it is not that you change it, but it is better to change. And the last sentence is very, very important. Though filter is not closed, you are not getting any alarms, but if the patient's blood results start showing poor clearance of the solutes, even the CRRT is ongoing, that is urea, creatinine and potassium levels, it is the time to change the filter. This lesson I have learned when my practice as assistant professor in SWIMS, because majority of the dialysis patients, they get thrice weekly dialysis, but when we check the labs, their hemoglobin is not good, their general well-being is not good, their nutrition is not, but they are telling we are getting 4 hours of dialysis. That is not, lot of recirculation might have been happening in the fistulas, and also what you are giving is not important, what the patient is getting is important. This is where we need to change the filter. These numbers are only for us to guide as a monitor, but we don't rely completely on the numbers. So I have said so many things about pressures, alarms. Why do you think I am really important? Can anyone tell who these two people are? Recently I did my MBA certification from Healthcare Management, ISB Hyderabad. So after that my outlook has been changed at healthcare. So these two people are Dilip Raman and Dhruv Joshi, and they are the founder directors of Cloud Physician. The next big thing that is going to happen in medicine is Cloud Physician. See, what is this person does? They both are intensivists from Cleveland Clinic, Australia, and they came to India and they have set up this in Bengaluru, Cloud Physician. So someday you may not be doing CRRT sitting in Tirupati or Gunturu, or you may not be doing even when you are practicing in Hyderabad, but you may be called to see the monitors and alarms. So this person's duty, they adopt the hospitals, they make some, I don't know, maybe some settlements with the hospital, what to do and what not to do, and they try to monitor these monitors. See, Hyderabad, we have so many experts here, but the same is not true in the periphery. So at these peripheral hospitals, they are taking and they are monitoring the hemodynamics and everything at a peripheral hospital, and they are giving the treatment, and they are, they have signed with 5 more hospitals in the last 2 months. Varanasi, Pune, Ahmedabad, they have been taking up the hospital. So we don't know, maybe in future we may be called from them to give opinion on these alarms and monitors only, because the technician at the periphery, they may not know this, and we need to give decisions on this. So apart from monitoring our own patients, this is very, very important, and the future of medicine is going to be this. So this is about alarms and troubleshooting. The next talk will be monitoring and complications. So there are many complications when the patient is on CRRT. So vascular access and patency complications, I am not going to deal in detail with this because it is similar to the IHD. The next is electrolytes and acid-base disorders, normoglycemic ketoacidosis, drug clearance, nutritional and physical deconditioning, volume-related cardiac stunning, hypothermia and hematological complications. In this, I try to put my own case scenarios and come out with the solutions. So this is a 35-year-old male, acute pancreatitis, severe sepsis with MOTS with AKI and urea. Blood pressure is 80/40 on dual inotrope support. BP was maintained to 90/50 on triple inotrope support, initiated on CRRT. Can you identify the label part? Can anyone tell from the students what could be this? Nowadays dating is so common, no? Before you take up a girl into your life, it's spending some time. So just spend some time with your mission. That is very, very important. Don't entirely depend on technicians. Spend some time with your mission. Know every part. So nobody? Sir, you can answer any questions. Thank you for that, sir. So this is the blood warmer. If you closely look at into the CRRT machine, this is the blood warmer. The temperature is set at 41 degrees centigrade. And see this tube. This is in this blue tube we will keep the blood line so that the blood before goes to the patient gets warmed in that. So this patient is in severe hypothermia, severe shock. So we don't know whether shock has caused hypothermia or hypothermia has caused the severe shock in this particular patient. So we try to manage the recent machines have all this. Previously we don't have these warmers also in the machines, and we used to, and before correcting this hypothermia there are a lot of discussion. Some say that hypothermia is very good because it is going to protect your brain, it is going to decrease your metabolic rate. So everything needs to be individualized. You see hypothermia, immediately don't jump and go and start warmer. So try to assess correcting this hypothermia would be beneficial to the patient, then only go and correct this. The various methods, passive external rewarming blankets and all. In my ICU, we have a big machine, external warmer is there, big tube is there with the blanket and all. So they definitely do raise the temperature, because when I go and check the feet of my patient, I feel so hot. That definitely is going to improve the blood pressure of your patient. Active external rewarming methods like internal rewarming, like intravenous fluids warmed up to 42 degrees centigrade, and crystalloids into the stomach. Of course, these things we don't do. Fluids warmed up and the external warmer and modern dialysis machine with warming devices, we do use this in our unit. Case 2 is a 52-year-old female, urosepsis with septic shock, requiring dual inotrope support and maximum doses had AKI with metabolic acidosis and oliguria. Blood pressure is 80/60. She was on NIV support, started on CRRT. It is continuous for 36 hours. BP improved, inotropes weaned off, urine output improved, everything was good, but she is persistently on NIV. We are unable to, because they want to shift to room. ICU is very costly, but we are not able to wean off from the NIV. What should we do? What exactly has happened is, we take a sleep consultation. Unluckily, the patient also had a OSA component. She was given BiPAP, she was corrected. But what could have been the possible etiology in this patient? Can anyone tell? Yeah, I heard the right answer. I am happy because people are listening since morning. So hypophosphatemia. So it is important to know that hypophosphatemia is typically an avoidable complication. Why it is not so in HD? HD is also equally effective, but in CRRT we are going to do that for a longer period of time. So the incidence of hypophosphatemia is very high. And they are also extremely catabolic, malnutrition, GI losses, severe. These are the multiple causes. So for all these reasons, contrary to the patients on MHD, patients who are critically ill with AKI have higher rates of hypophosphatemia, and if it is less than 1.8 milligrams per deciliter, it has been shown that it increases the incidence of duration of mechanical ventilation and increased need for tracheostomy. So your patient on CRRT difficult to wean off, then definitely go for a checking for, because we do monitor phosphorus daily. Like Mahesh, we are all not lucky to have fixed protocols, trained technicians. We all work with a limited resources, right? We need to train them and we need to check. So in my unit, I check calcium, phosphorus, magnesium daily when the patient is on CRRT. So patients receive oral supplementation, like morning Rashika sir told. Now we have IV phosphorus also. Recently I had one patient, he improved with the oral phosphorus solution. This same lady, we have given oral phosphorus solution through the Riles tube, and she has come out, and just 2 days back she came for the follow-up, and the son's complaint was, we bought BiPAP 30,000 rupees which is of no use now. So we could have saved that 30,000 for the lady, but during that point of time we want to bring out the patient. We did everything for the patient. So those developing hypophosphatemia, despite maximum oral supplementation, they can give IV phosphate. So this is the reference that I have taken from. Of late, we also, in India, we don't have phosphorus containing bags. We all have this, but there are phosphorus containing CRRT bags coming up now, wherein we don't have these complications, which is Foxilium. I think this is not available in India, sir. As Bifosal is there, sir. Yes. So next is the thrombocytopenia. A lot has been discussed in the last talk about thrombocytopenia, but what is very important is, don't blame CRRT as the cause of thrombocytopenia, because a patient on CRRT already has multiple complications. It's very severe. Sepsis itself can cause thrombocytopenia. In my unit, most of the patients are CAD, post-PTCA, cardiac surgery patients. So they are on continuous heparin for the last 1 week. And we start him on CRRT. Next day, the counts are 90,000. They say that CRRT has caused thrombocytopenia. So to blame it as CRRT-induced thrombocytopenia, the previous 4 days should be normal thrombocytopenia. And the most important thing that I would like to take home from this lecture is thrombocytopenia in a patient on CRRT is not only a number, it is going to tell about the prognosis of the patient, where the study by Griffin et al. Has shown that if the platelet count has dropped by more than 40% after initiation of CRRT, they have seen that the recovery of renal recovery is very late and also higher mortality on CRRT. So management is variable because the targets are very different. In my unit, what we follow is till 30,000 we don't do any intervention unless the patient has some bleeding complications, or if the patient is posted for some surgery, if the counts are less than 10,000, we do give prophylactic FFPs. And and from the mission side we can improve the rheology by increasing the blood flow rate. So rheology I'm not going to discuss in detail. So thrombocytopenia we have to monitor daily. So this is the simple slide which tells about the rheology. So the blood in the middle layers, it is going very smoothly, but the blood that touches at the periphery of this, there will be more viscosity, and platelets try to get aggregated, adsorb and activate at the periphery. If you improve the blood flow rates, this peripheral activation could have been come down, and morning we have seen that the DX component will come down by increasing the blood flow rates. Okay, sir. Case 3, 74-year-old male, known patient of DCMP with IC. This is a very interesting case that I have seen just 2 days back, sir. So he had history of fever and acute GE. He came to us with creatinine of 4 and decreased urine output. But his blood pressure was 90/60. So immediately I started him on sled. That was the protocol. So but he had sudden hypotension after 1 hour of dialysis, and we need to stop the dialysis. And as soon as it is because of dialysis, they blamed it, and next day we have to come and see. Luckily, this patient had ICD. So we could see what has happened with him. So next day we have started this patient on CRRT. But similar thing has happened. He had another episode of sudden hypotension with severe tachycardia, VT, and the procedure has to be stopped. So this is the program that we have read from the ICD, and if you see that 36 treated VT and VF episodes which are longer than 30 seconds have happened in this particular patient. So we all know that cardiac arrhythmias are very common with IHD or SLED, but they do happen with CRRT. The best thing is this patient has ICD, so I can tell that this has happened. But there is something also called as cardiac stunning also do happen in patients on CRRT. So when the patient had cardiac complications, again it was polymorphic VT, so immediately our cardiologist said it could be some other cause, it is not monomorphic. So we checked for all the electrolytes, hypocalcemia, hypomagnesemia were all ruled out. So it is always imperative, and we do monitor calcium, magnesium and phosphorus. At least calcium and potassium we do 6th hourly in the initial first 24 hours. Then we change where we need hourly. If the patient is stable, we do monitor daily. Cardiac complications, especially cardiac stunning, is more described, but this particular complication of arrhythmias is also seen in some patients. Next slide is based on the nutrition. I'm not going in detail, but these people are highly catabolic and they require very high protein requirements. It is discussed 17 gram per kg per day. And also important is we need to consider the calories that are coming from citrate and lactate also, because they are going to get converted to ATP. And there are very high risk for physical act because they are connected to multiple machines. We tell physiotherapy also, physiotherapists won't come to my patient only, but I tell no, you have to take some form of movement, because ultimately he will come out of this condition, he will die of PTE, pulmonary thromboembolism. So that is also very, very important. Continuous motivation and coordination between ICU and physio team would help in early rehabilitation. So that completes my second part, sir. So now moving to the third part, drug dosing in CRRT. So I'm not going to tell each and every drug, just some basics that you have to remember when you want to give some drugs during CRRT. This we have discussed in the morning, SC and SA. The ratio of the solute concentration in the ultrafiltrate to the solute concentration in the blood is Sewing coefficient. So at least look at when somebody comes to you and asks buy our dialyzer or buy our machine, just try to look at this SC and SA so that you will have an idea what you are going to give to the patient. SA is the ratio of solute concentration in the dialysate to the blood. So if SC or SA is equal to 0, just remember this. If on the filter background you see SC or SA is equal to 0, that means all drugs cannot pass through this membrane, which is ideally doesn't happen. SC or SA is equal to 1, it represents all the drugs can be filtered through the CRRT membrane. So this is very important when you dose your antibiotics on CRRT. So CRRT membranes have increased pore size and they can remove larger molecules effectively. As we have discussed, polyacrylonitrile filter membrane has increased adsorption of this gentamicin and tigecycline. So tigecycline we are using very frequently nowadays. So I tried to mention, and piperacillin tazobactam, most of my gastro colleagues would like to use it. So the dose, and they have seen that AN16 and ST membranes required higher dyes of piptaz dosage, uh, and the increased membrane surface area might partially account for the augmented drug. So if you go on for efficiency, then you have to go on increasing the dose of the antibiotic also. There is no point urine comes out. Sometimes it happens with me also. Urine comes out, creatinine becomes normal, but the patient dies of severe sepsis. So that is very, very important. You need to increase the doses of antibiotic when the patients are on CRRT. So it also depends upon the dilution mode. We have discussed morning, everything is so good in pre-dilution because it decreases the viscosity and all. But the problem with pre-dilution is, if the antibiotic clearance also will be higher. If we give in, it will be lower actually. So effluent flow rate is also important in this. This has been already told that at least you target to 20 to 25. Even if you give 25 in the mission, what we are going to get is always less than 20 or near to 20 and 21. So higher flow rates increase the clearance. So we try to increase the flow rate to get the more efficiency. But if you increase the more flow rate, your removal of antibiotic will be also more. So at the same time, increase the flow rate, increase the antibiotic dose. This you need to remember. So gross things we need to remember is CRRT increases the clearance of the drugs which are removed by the kidney. So that is very, very important that you remember. And morning Rajshekar sir has added a beautiful point. 10 ml of effluent is equal to 7 ml of GFR. So try to add it. It helps us giving more because we are tuned to that. GFR more than 30 this dose, less than 30 this dose. So try to add that effluent GFR also to your normal GFR. So drugs with small volume of distribution are hydrophilic drugs. They are eliminated by renal. So low VD, usually greater clearance with CRRT. So finally, the take home on antimicrobials, I would just like to discuss this point. Whenever somebody calls you and asks what is the dose of antibiotic, just tell whether this antibiotic is a dose dependent antibiotic or time dependent antibiotic. If you want the antibiotic to be present more in the blood, try to give in a infusion setting, or if you want to antibiotic to be very high at certain point of time because it is dose dependent, then try to give bolus dose. So don't try to change the bolus dose in this antibiotic. And ultimately, we all have learned in our epidemiology, outcome of any disease depends upon the agent, host, environment factors. Similarly, when you try to discuss a drug dose in CRRT, look at all these three factors: patient factors, drug PK PD factors, and CRRT machine, and also modality. What I would like to stress upon is hemofiltration has a different dose, HDF has a different dose, HD has a different dose. Somebody asks you for drug dosing, ask for what is the modality, what is the membrane, what is the hemodynamics, and at the back of things you know what type of antibiotic it is. We all know whether it is renally cleared or liver cleared.
You have another 45 seconds to finish your talk.
Yeah, so I'm not going to tell all these things, sir, but these are the common drugs. Ultimately, what I would like to just discuss is meropenem, because I don't think any ICU without meropenem would go for our day. So loading dose of 1200 mg and maintaining doses of 600 to 1800 mg 24 hours achieves a good trough levels so that we can save our patients. And similarly in HD, it is a little lower dose, 800 mg and 400 mg. I don't tell you to memorize all these things. There are certain things that we don't need any dose adjustment. We can happily try to memorize this: ceftriaxone, tigecycline, capsofungin, oral form of voriconazole, clindamycin, linezolid. Next thing can be added by you, because the trials on drug dosing in CRRT are still going on. There are no clear-cut guidelines on what dose, what drug. So you may be adding the next thing. And this is the beautiful paper that I read before presenting to you. If you have any doubt during your prescription, you can go through this. Recommendation of antimicrobial dosing optimization in CRRT. They have given about every drug. You get posaconazole also they have given. We need to give very high normal dose of posaconazole in CRRT patients. So you can check with this article. This is my memories with NIMS. I thank my teachers, because of whom I am like this and I am here. Previously I used to be there. I used to be anchoring all the proceedings in NIMS. Now I am here. It is because of my teachers. And next thing is, big thing is my patients, because they have confidence in me. I am able to treat them, and these are my staff at my Amara hospital. I could not get a beautiful picture. This was during our World Kidney Day. So these are my patients. I thank to them, because without whom I would have got this experience. Knowledge I can gain from my textbook, but patients, they only taught me this experience. Thank you so much. Thank you, sir, for taking a lot of time.
No. So excellent talk, Dr. Siva Parvathi. Keeping aside science, the presentation is simply outstanding
Thank you.
because you had about 4 to 5 bulleted points per slide max, and you used images wherever it's needed. There was no data dump, and this is just what the doctor ordered. And it's one of the outstanding presentations I've ever had. And you
Thank you,
almost
sir.
spoke like a fifth grade teacher teaching school students, very humble basics, down to earth kind of a talk, and it speaks volumes about your program, the nephrology program you had been on, obviously NIMS. Now, a couple of points I'd want to make is this. I know in your temple town people don't drink alcohol, perhaps, but we see a high burden of alcohol, liver disease patients at AIG hospital, due to which we end up at almost 50 to 70 CRRTs per month. Pretty high number when you compare to the rest of the numbers across the country. Our concern is that CRRT is a major menace to our life because it's putting a lot of burden on doctors, technicians. It's because of these alarms and monitoring. And we also have a selection bias that the moment blood pressure comes down to 80s and 90s, we resort to CRRT. Do you think if you were to be a director of the CRRT program in a big hospital, are there 5 or 6, maybe 4 to 5 preventive strategies to overcome these alarms and monitorings in general?
So the best thing that I would say, or the first experience of CRRT that I have had in NIMS was under Gangadhar sir. We have done in a cardiac patient. Actually, sir also might not. He was there with the patient. Blood pressure is 160 only. Then we thought, why sir is starting CRRT? Blood pressure is okay, 160, but he is post-PTCA patient. So try to anticipate the problems. Try to anticipate the complications. There is no point once you start the patient on 80, 60, triple inotropes. We are not going to gain much unless we complicate ourselves. Though they may say that it is consuming more money and all, after that the patient was discharged in 2 days. So that day I realized, so even now, actually Rashekar sir is not there. He told, we are not creatinine centric at all, sir. In my hospital, I tell to all my intensive staff, don't look at creatinines. I get calls predominantly for 2 reasons. One is decreased output, the other is acidosis. So they look at these 2 things, and if we start CRRT for these 2 things, we are not going to get much complications, sir. So anticipating the complications and choosing the right patient at the right time will prevent us from getting all these complications. That's what is my knowledge till date, that I had some experience. But I should say frankly that I don't do much for liver disease patients, sir, because we don't have liver transplant as an immediate bridge, because this is done only as a bridge to transplantation. We don't do at our institute, sir.
So some of the intensive care practices in the United States give standard dose of antibiotics in the first 48 hours, irrespective of GFR, for intensive care patients. What are your thoughts about it?
I do agree with them, sir, because unless the patient is some form of RRT, even if he is on HD, because if the patient is on HD or SLED or PD or CRRT, it means that literally the kidneys are not functioning. What we were taught as patient first, organ next. So I follow the same principle. When I go with my intensivists, they want to give certain times very high antibiotic dose. Yes, give the dose. Then we will take a call on renal replacement or something else, because life is first, then the organs, sir. That is what I practice. I don't know. I have to listen from the hall. Thank you.
No, Siva Parvathi, that is a great talk as usual. We always love to hear to you.
Thank you.
And maybe back to NIMS hospital and with all your memories. The one thing I wanted to remind you is, you said the future is our cloud monitoring. It's not future, we are doing in our hospital. So we have this intensive ICU. So where
Yes,
our intensive Dr. Padmaja madam, she has been attached to many peripheral ICU centers. They do that monitoring. And we are also coming with our own dialysis, our hub dialysis and peripheral dialysis
Yes,
centers. We have come with a nephroflow where we can monitor the machine, we can monitor sitting over here. So it's
Yes,
not a future, that is present actually.
Yeah, of course. I mean, it is getting very deep into the peripheries, ma'am. Actually, nowadays these 2 people are really dynamic. They are taking a lot of hospitals in Varanasi, Bombay, and Ahmedabad. Metro cities, they don't need any support. Like we used to do in telemedicine in other hospitals also. In NIMS also, we used to talk to the patients and all. It has been there, but it has picked up its momentum. I don't know, maybe in 5 to 6 years, we may be doing all that.